Welcome to our series on geographic atrophy. This companion podcast resource is supported by educational grants from Apellis Pharmaceuticals, Astellas, and Topcon Healthcare. In this episode, two retinal specialists discuss the case of a patient presenting with bilateral geographic atrophy with foveal involvement. Today, we will hear how the patient's story illustrates both the challenges of central involvement and the benefits of complement inhibitor therapy.
Let's dive into this case. This was a patient of yours, a 68-year-old woman who came in with decreased vision in both eyes.
Right. She was a former smoker who quit 3 years prior. Her acuity at baseline was 20/125 in the right eye and 20/100 in the left. Imaging showed bilateral GA with foveal involvement.
And even with central involvement, even though vision was already down, she was still motivated. She wanted to hold on to what she had to keep her independence and preserve as much function as possible for daily activities. That's something we see a lot. Patients with moderate impairment who very well may still have quite a bit of life ahead of them and want to preserve vision for as long as possible.
Exactly. So the key conversation here is about expectations. We're not restoring vision, we're slowing things down. The goal is slowing progression and preserving what's left. And in her case, she opted to enroll in a clinical trial with monthly injections of pegcetacoplan in the right eye, while the left eye remained untreated.
That's an important strategy. Start in one eye, usually the worst one, both to monitor tolerance and to give patients a comparison point.
Exactly. Especially for someone new to injections, it helps them see what's happening and builds confidence. And it also allows for us to watch for any signs of intraocular inflammation.
The progression of GA is rough. In AREDS, median time from developing GA to seeing central involvement was only about 2.5 years. And in AREDS 2, 60% of eyes progress to foveal involvement within 4 years. And once that happens, that loss is irreversible.
Yes, and that's where the benefits we've been seeing with complement inhibition come in. In the OAKS and DERBY trials, treatment with pegcetacoplan slowed GA growth by about 15 to 20% in the first year, and this benefit was sustained through the end of the trials at month 24. The long-term GALE extension study found that the treated eyes were growing at about half the rate of the untreated eye. And by month 36, the mean rate of change in GA growth decreased by about 32% across all eyes, compared with that of the projected sham group. And in non-subfoveal eyes, reductions were even greater, with benefits persisting among treated eyes through month 48. Safety-wise, we did see a higher rate of new wet AMD, anywhere from 5 to 14%, depending on dose and duration. But intraocular inflammation and endophthalmitis remained rare, and overall the risk was manageable.
So, what happened with this patient?
After 3 years of monthly injections in the right eye, fundus autofluorescence showed 3 times greater GA growth in the untreated left eye.
And her visual acuity tells the story. The treated eye held steady around 2100, about 43 letters, while the untreated eye lost about 20 letters.
That's fairly striking. Within-patient controls like this really highlight the effect of treatment. The fellow eye really serves as the control. You can literally show the patient the difference.
Exactly. And this is where discussing the benefits and risks of treatment with patients is so important. I tell them, you're not going to see better, but we can slow down the decline. For patients who are still active, those using low vision aids, those still driving or reading, this can make a huge difference.
And keeping them motivated is part of the job. If you just walk in, give an injection, and leave, it's hard for patients to stay committed. Taking a moment to review their images, show them the comparison, remind them what we're working to preserve, that makes the difference.
Exactly. It builds trust and helps them see we're on the same team.
So to summarize, even in the case of GA with foveal involvement and moderate baseline impairment, treatment with complement inhibition can preserve vision and slow progression.
This case really highlights the benefit of treatment with complement inhibitors, the importance of patient education and setting expectations, and the role of long-term monitoring.
And as we continue to build evidence, the message is clear. We finally have tools to help our GA patients, even in challenging cases like this one.
That concludes today's case discussion. This patient's experience shows how complement inhibitor therapy can meaningfully alter the course of geographic atrophy, even with central involvement. To read through this case and earn CE credit, you can follow the link in the description to helio.com, where you will find this case presented as an ACE the Case activity, along with a variety of additional CME programs. Also, please check out the other podcast in this series, which discusses imaging technologies for diagnosing and monitoring geographic atrophy.